Ever get the feeling that some medical conditions are like mystery novels, full of twists and turns?
Mm-hmm.
That's exactly what we're diving into today, pulmonary embolisms,
Okay.
or PEs for short.
All right.
We're going to unpack some research that could literally be a lifesaver. So
Yeah.
buckle up.
You're spot on. There's a lot more to PEs than meets the eye,
Right.
and understanding the nuances can make all the difference.
Okay, so to set the scene, let's start with the story from the research.
Okay.
Imagine a 71-year-old woman goes to her doctor. She's tired, short of breath, has a cough, maybe even a scratchy throat.
Mm-hmm.
Pretty common stuff, right?
Yeah.
Even mentions a heavy chest.
Right.
Her doctor figures it's her heart failure acting up, or a lingering cough, tells her to rest, drink fluids.
Yeah.
Sounds reasonable so far, wouldn't you say?
It does sound plausible, especially given her age and existing health conditions.
Exactly, but here's the catch.
Yeah.
A few days later, she's back, struggling to breathe.
Oh.
Turns out it wasn't her heart or a cold,
Wow.
but a blood clot in her lungs, a PE.
Wow.
And sadly, this scenario is more common than you might think.
What's fascinating and concerning is how frequently pulmonary embolisms fly under the radar initially.
Right.
See, a PE happens when a blood clot, often from the legs,
Huh.
breaks free and travels to the lungs, blocking blood flow.
Okay.
This can look like shortness of breath, chest pain, even just a cough.
Wow.
These symptoms are so common that they're easily mistaken for less serious conditions.
And this isn't just a rare thing, right? It feels
Yeah.
like I've been hearing about PEs more often.
You're picking up on something important. Studies actually show that PE incidence has doubled in recent decades,
Really?
likely due to better detection methods.
Hmm.
We're also seeing it more frequently in individuals over 70.
Okay, that's definitely got my attention.
Yeah,
And I'm guessing early diagnosis is key here.
absolutely. Early diagnosis is crucial because it has a huge impact on how effective treatments are.
Right.
In fact, when we catch it early and start anticoagulation,
Mm-hmm.
it significantly reduces the risk of that clot coming back,
Okay.
what we call venous thromboembolism or VTE recurrence.
Hold on. VTE. Is that different from a PE?
Good catch. VTE is the umbrella term.
Okay.
It stands for venous thromboembolism and includes both deep vein thrombosis,
Hmm.
DVT, which is the clot in the legs,
Okay.
and PE, the clot that travels to the lungs.
So when we talk about VTE recurrence, we're talking about that clot reappearing anywhere in the venous system.
Precisely. And the beauty of early anticoagulation is that it not only prevents clot extension and promotes the existing clot to break down,
Right.
but it also seems to reduce long-term complications,
Okay.
like chronic thromboembolic pulmonary hypertension,
Okay.
or CTEPH.
CTEPH, that sounds serious.
It is.
Yeah.
It's a rare but debilitating condition that can develop after a PE,
Right.
leading to high blood pressure in the lungs and potentially heart failure.
Wow.
Early treatment is our best defense against these long-term consequences.
Okay, that makes the need for early diagnosis crystal clear. But if it's so important, why is PE so often missed in the first place? So we've established that early diagnosis is key, but it sounds like spotting a PE early is easier said than done. What makes it so tricky for doctors to connect the dots?
You're right, it's a real challenge, and it comes down to a few factors. We've touched on how the symptoms of a PE can be quite general,
Right.
mimicking other common conditions like a cold, heart failure, or even just a bad cough.
Right. So a doctor might initially focus on treating the more obvious or familiar culprit.
Exactly. And to add another layer of complexity, many individuals with a PE don't have the typical warning signs of a blood clot in their legs,
Oh,
like
I-
swelling or pain.
Right.
This makes it even harder to suspect a PE, especially if the symptoms are vague or gradual in onset.
So someone could have a potentially life-threatening blood clot in their lungs without ever experiencing the classic leg symptoms.
Right.
That's pretty scary.
It highlights why it's so crucial for both patients and healthcare providers to be aware of the less obvious presentations of PE.
Yeah,
We can't rely solely on the textbook picture.
that makes perfect sense. So how do doctors navigate this diagnostic maze? Where do they even begin when a PE is suspected?
It's a multi-step process.
Okay.
And thankfully, we have some valuable tools to guide us.
Okay.
The first step often involves using a clinical decision tool,
Okay.
like the Wells or Geneva score.
Right.
These scores take into account the patient's individual risk factors, their specific symptoms,
Mm.
and how likely a PE seems based on the initial assessment. It's like a quick but informed estimate of the probability.
So these scores help doctors prioritize who needs further investigation.
Precisely. If the score suggests a low probability of PE, The doctor might opt for a less invasive approach,
Right.
like a D-dimer test.
Okay, D-dimer. I've heard that term thrown around, but I'll admit I'm a little fuzzy on what it actually tells us.
Sure.
Could you break it down for me?
Absolutely. A D-dimer test is a simple blood test
Okay.
that measures the breakdown products of blood clots.
Okay.
When a clot forms and then starts to dissolve naturally,
Uh-huh.
it releases these D-dimer fragments into the bloodstream.
Okay.
An elevated D-dimer level basically tells us that there's been some recent clotting activity in the body.
So if the D-dimer is high, it means there's definitely a PE, right?
Not quite. It's a bit more nuanced than that.
Okay.
While a high D-dimer suggests that there might be a clot somewhere, it doesn't pinpoint the location or the cause.
Right.
It could be a PE,
Okay.
but it could also be due to other factors like an injury, recent surgery, infection,
Right.
or even pregnancy.
So it's more like a clue that warrants further investigation rather than a definitive answer in itself.
It's all about putting the pieces of the puzzle together.
Right.
A high D-dimer raises a flag, especially if the clinical suspicion is already there,
Right.
but it doesn't automatically equal a PE diagnosis.
That makes sense. We don't want to jump to conclusions, but I remember you mentioned earlier that the D-dimer test isn't always reliable,
Right.
particularly in older adults.
Yeah.
What's the issue there?
That's a critical point to consider.
Yeah.
As we age, our D-dimer levels naturally tend to rise.
Hmm.
This means that the standard cutoff point used to interpret the test
Right.
becomes less accurate in older adults and can lead to false positives.
False positives meaning the test indicates a PE when there isn't one.
Exactly.
That doesn't sound ideal.
You're right. It can create unnecessary anxiety and potentially lead to additional testing that might not be needed.
Right.
It's like getting a false alarm.
Yeah.
It highlights the need for caution in interpreting the results, especially in older patients.
So how do we address this challenge of D-dimer accuracy in older adults?
Yeah.
Do we just disregard the test altogether for that population? So we don't just toss out the D-dimer for older patients.
Right.
We adjust our approach.
Right.
Like it.
Precisely. We've made some impressive strides in refining our diagnostic tools. One way we address the issue of age and D-dimer levels is by using, you ready for this?
Yeah.
Age-adjusted thresholds.
Age-adjusted threshold.
Yes.
So basically, we move the goalposts a bit based on the patient's age.
Exactly. It's about recognizing that what's considered normal for a 30-year-old might be different for a 70-year-old.
Right.
These age-adjusted cutoffs significantly improve the accuracy of the D-dimer test in older populations,
Okay.
reducing those false alarms we talked about.
That's reassuring. Are there other strategies to minimize unnecessary scans? I mean, no one wants to be exposed to radiation if they don't have to.
You're absolutely right, and that's where some of the newer algorithms come into play.
Okay.
Take the years algorithm, for example.
Okay.
Instead of just a simple yes-no based on the D-dimer level, years incorporates clinical factors like the presence of certain symptoms, signs, or risk factors,
Okay.
along with the D-dimer result to give a more personalized risk assessment.
So it's like a more sophisticated detective using all the available clues to get a clearer picture.
Exactly.
I like it.
And there's another one called the 4-PEPIS algorithm,
Okay.
which uses a similar concept of combining clinical information with the D-dimer result.
Okay.
These strategies are showing real promise in reducing unnecessary CT scans without compromising patient safety.
Fascinating. It seems like we're getting better and better at walking that tightrope between being thorough and avoiding unnecessary interventions.
Yeah.
But let's say the D-dimer is elevated or the clinical suspicion is high enough that further investigation is warranted.
Right.
What happens then? What's the next step in our diagnostic journey?
That's when we typically turn to imaging.
Okay.
And when it comes to definitively diagnosing a PE, the gold standard is a CT pulmonary angiogram, or CTPA for short.
CTPA. Break that down for me. What is that exactly?
It's a specialized type of CT scan that gives us a detailed look at the blood vessels in the lungs.
Okay.
By injecting a contrast dye into the bloodstream, we can actually visualize the flow and see if there's any blockage caused by a clot.
So the CTPA gives us a definitive yes or no on the PE diagnosis.
In most cases, yes.
Okay.
It's very good at detecting a PE when it's there. We call that high sensitivity.
Okay, but what about the radiation exposure that comes with a CT scan? Are there any alternatives for patients who might be more sensitive to those risks?
That's a valid concern, and we always weigh the risks and benefits for each patient. There is an alternative imaging test called a VQ scan, which stands for ventilation perfusion scan.
Okay.
It uses a small amount of radioactive material to create images of the lungs and show how well air and blood are flowing.
Right.
This option exposes patients to less radiation than a CTPA.
So depending on the individual's circumstances and risk factors, there are options to consider. That's good to know.
Absolutely.
This deep dive has been eye-opening. Thinking back to the 71-year-old woman we discussed earlier, could her PE have been caught sooner with these diagnostic strategies?
It's tough to say for sure, but knowing what we know now,
Right.
there were definitely some missed opportunities.
Yeah.
Her age alone put her at a higher risk.
Right.
And her symptoms, while seemingly mild, warranted closer attention.
Right.
Especially that progressive shortness of breath.
And utilizing a decision tool like the Wells score or the D-dimer test, especially with age-adjusted interpretations, might have changed the course of her diagnosis.
Absolutely. Her case is a powerful reminder that we need to keep PE on our radar even when the presentation is atypical.
Right.
Especially in older adults where those textbook symptoms might not always be present.
It sounds like communication is key here.
It is.
What can individuals do to advocate for themselves if they suspect a PE, especially if their symptoms don't fit the classic mold?
That's such an important question. If you're experiencing unexplained shortness of breath, chest pain, or any of the symptoms we've discussed,
Right.
don't hesitate to seek medical attention.
Right.
Be direct with your healthcare provider about your concerns.
Yeah.
Let them know if you have any risk factors for PE, like a family history, recent surgery, or prolonged immobility.
Basically, if something doesn't feel right, speak up.
Exactly. Early assessment is everything.
Right.
It's always better to err on the side of caution.
This has been an incredible deep dive.
It has.
I feel like I've learned so much, and I hope our listeners feel empowered to be their own health advocates.
Me too.
Until next time, stay curious and stay informed.